just counting us down to Facebook. Hi, Facebook Live. And welcome to another weekly infusion. Bruce is still in Scandinavia, Dr. Bruce. He's missing some good shows here, but you guys are all deriving the benefits of his absence. And I get the pleasure of having lots of interesting and cool guests. And today I've got Dr. Elliot Hirsch. He's a board-certified plastic surgeon. And you practice here in Los Angeles?
I do, yeah, primarily in the San Fernando Valley.
Dr. Hirsch and I met because he did a rotation where I was teaching at a psychiatric hospital. Look at Tani Kitean's going to be here. There's Tani. Tani's there on the Facebook Live. You're there. You're right. Okay, I need to introduce Tani because she's in our picture with us. I'm sorry, I didn't see you back there. Tani Kitean. Everyone knows Tani. We're going to get her into this conversation very quickly to talk about her experience on botch and her campaign about breast implants and the complications she went through that you haven't seen on television yet. And we appreciate you having the eternal recurrence there.
I've got it covered.
In any event, he and I met at that rotation when he was a medical student. Then I spoke at your graduation.
Absolutely, yeah.
And then you went on to do a general surgery residency. And were you all the while planning to do plastics?
Yeah, it was actually it's one of the newer programs that's integrated plastic surgery. Now we'll talk about the training and all that stuff.
We will. We're going to talk about it later in the show. We're going to talk to Tani about her thing now. I want to talk about your practice before we get Tani into this conversation. Any special area you're interested in now, or where your practice focuses?
Mainly breast surgery. Yeah, I do, on every month about 40 to 50 surgeries, and probably 75% of them are breast, either augmentation or reduction, implant removals, lifts, cancer reconstruction.
Do you do that famous cancer reconstruction at the same time as the mastectomy?
Yeah, absolutely.
Yeah.
It's better for patients.
They wake up and they feel so much better when they have something there. Yeah. So that to me was one of the cool advancements in reconstructive.
Definitely.
Yeah. So what we're talking about is that you can go in for a mastectomy, or whether it's because you have breast cancer, or the real interesting thing is for the people that are doing it prophylactically.
Sure. Yep.
And you wake up and you have newly reconstructed, very cosmetic, not just acceptable. People are very happy with what they've got oftentimes. But that's a special situation. Anything else besides breast, the other surgeries?
Yeah, and I do the full spectrum of plastic and reconstructive surgery too, not just the aesthetic things like eyelids and facelifts and tummy tucks, but occasionally you have patients who've lost a lot of weight and they have the hanging skin, patients who can't breathe, who have functional rhinoplasty problems, and then even occasionally we'll do a little bit of trauma where a patient gets in a car accident and they need somebody to put them back together.
How about the old flaps for wounds and things like that, all that kind of stuff?
It's a rare day, but
really,
yeah.
That used to be such a. You just don't like doing that, or that used to be such a thing plastics did.
You know, the thing
at least on my end of the spectrum, where on general medicine, we're doing lots of wounds. We're always calling plastics to flap them.
It's always, once you get out of the hospital, those things are best managed with a team.
Right, that's right.
You know, when you're by yourself, you got to manage the nutrition. You have to make sure they're following the instructions.
Yeah.
Once by the time they get ready for a flap, the wound often heals itself, and then you look great because you actually have to do surgery and you got the problem solved.
Fair enough. All right, so to Tani, I want to introduce you now to the program. Everyone knows Tani. How shall we introduce you at the present time? How do you like to be known?
I'm alive and I'm doing great, and my name's Tani Kitean.
Look at Tani. Tani, everyone knows Tani from. I knew her from back at Celebrity Rehab. Everyone knows her from back in the '80s when she was. How would you characterize it?
Yeah, we did Love Lines back in the 80s.
We used to do a Love Line back all the time, too. That's right, too. I knew Tani from way back. I forgot. And how are your kids? Everybody good?
Thank you so much. Rainey, I think like most students, well, I'm not sure. I think most students, this is either this or my friends are just trying to make me feel better. Rainey dropped all her classes the first week. Well, she dropped them and she said, I didn't like my English teacher. I didn't like my math teacher. I'm getting all new classes.
Good.
And I thought, when you drop one class and you don't like the teacher, it's probably the teacher. When it's all your teachers, then maybe there might be a hint of
but Tani, I'm going to tell you something. The way that she's how old now?
She's 19.
Yeah, that age group, the way they do stuff, it's very different than what you or I would be used to.
That's right.
They really want things to be right for them, and they want to find their way, and they want it to be exactly what speaks to them. And I think they may be onto something. You know what I mean? It's very frustrating as a parent, but I think they're onto something.
I think you're right. And you'll love this because you're such a rock and roll guy as well. So one of her classes was the history of music, right? So she goes in and she calls me, I've dropped the class. And I said, why? And she goes, because it's like some guy named Bach and some guy named Beethoven, something like that. And she gets her new class and she goes, Mom, it's about Nirvana and Pearl Jam. And I was like, okay, you're in the right class now.
Perfect. All right, now you
Yeah.
you had a series of reconstructive surgeries that people saw your episode on botched. I'm actually going to let you do the interview because you're going to be more specifically to what she's been through. You'll be able to spell it out. You know, she was on an episode of Botch. It was a very popular episode, and she was very happy with the result. I've spoken to both Terry Dubrow and Paul Nassif, and you're like their favorite patient of all time. And I know you've had some complications following, which are miserable, but thank God not dangerous. And we'll talk about all that. But first, let's talk about your. What kind of dog? What kind of dog?
Do some more. Oh my gosh, I feel so bad. Can you hang on? The guard must have let someone through the gate.
It's all good.
Keep talking to nice Hirsch. Oh my gosh.
This is my favorite moment ever. This is fantastic. Oh, look at her.
Now
oh my God, you're so funny.
Culprit right here. I'm gonna have her sit with me.
Oh my God, that's so funny.
So, yes, as we were talking.
So as we were saying, so your first procedure was when and why?
My first procedure was after I had done a bachelor party, after I did all the rock videos. And I think, like I said on the show, just too much time on my hands, too much money, and a little bit of insecurity, and not really knowing who I was. I mean, you know, the brain, I'm sure as you both know, when you're 18, 19, 20, trying to make decisions, the brain doesn't really fully develop until you're the age of 25. Is that true?
Especially for the males.
Especially for the males, I would say probably 50. But
we'll give you that.
Yeah, well, thank you. And I don't know, it was just a mixture of just, listen, if I had to do it all over again, I wouldn't. But that was the situation. I was bored, little insecure.
How old were you then?
Money. I was 27.
Okay, so Dr. Hirsch, you have a 27-year-old coming in. She's a public figure. She's got lots of concerns about, you know, her career and wanting to keep things moving forward, right? How would you have dealt with that?
You know, the biggest thing with breast augmentation is to find out the patient's motivation for having the surgery. So I would say, Tani, what was your goal? Why did you do it? Or why did you go to the consultation?
Well, it's funny. It really didn't have anything to do with my career because at that time, Drew, I mean, you and I had already talked quite a few times. I had done Love Lidens with you.
Yeah.
It was really more of a personal choice, which I think had to fully stem from insecurity, from not really dealing or knowing who I was. And I thought maybe changing the outer of who I was, because like I said, it wasn't going to make me a star. I was already whatever star you want to, I already had notoriety. I didn't need that to enhance my career. It was a decision made for my personal self.
Yeah. And it's interesting because I've had this conversation with plastic surgeons over the years, which is when at times what I'll get back when I say, well, this is somebody who, you know, is coming from a place, maybe we want to explore what that is, what's motivating her. But what I've gotten back over the years was, well, more often than not, when we give them what they want plastic, some of that insecurity stuff settles down. Which I'm sure it does, but it sort of recedes. I'm not sure it goes away.
You know, breast augmentation, so it is the most common cosmetic surgery right now in the U.S. And you're talking almost 300,000 women a year who are doing this. And the patient satisfaction scores for breast augmentation, they're very high. Yeah. And most people are very happy. And you're talking...
And I have talked to women who think it was the best choice they ever made and stuff. And, of course, they've not gotten any revisions or anything done. They've been lucky that way, for sure. Yeah. And for whatever reason, it fit their needs, right? How do you find that population is the question then.
Well, I think it's a matter of listening. Yeah. And, you know, the ideal patient for a breast augmentation is somebody who maybe they're 18, 19, 20, 21 years old, kind of on the younger side. They've always felt insecure about not having breasts. So maybe they're afraid of changing in the locker room. They don't want to go out in the bathing suit. And this is Southern California. They don't want to go out in the bathing suit. And they just feel like they want to feel more feminine. The other ideal population of women to have breast augmentation are patients who maybe they have 1 or 2 kids, they're done having kids, and they felt like they really liked the way their breasts look while they were pregnant or breastfeeding, and then their breasts have deflated. They're kind of, they're kind of empty and hanging down.
Involutional changes.
Exactly, yeah, postpartum involutional changes.
So, Tani, you go ahead.
Well, to that, those are the women. That's who I am not speaking to.
Yeah.
Right.
In terms of, I agree.
Yeah.
Marriage, you're in a solid relationship, you've had a couple kids, and you want to feel like your old self again.
Yeah.
I am so for that. I think that's absolutely great.
Sure.
But I think the standard of being 19 and not feeling like you look good enough in a swimsuit has something more to do with what's going on up here, and not necessarily, in my opinion, on really what's going on out here, because we should all really be thinking about, well, okay, why don't you feel that way? And I think that's where the conversation needs to go.
Yeah.
For example, Gwen Stefani, Terry DeBro's wife, Heather, myself, all of us, we all had small breasts, and we were fine with that. It was until I was 27 that all of a sudden I decided, so there are a lot of girls that don't feel that way because they feel they're secure with who they are. So I disagree with it. And if they are going to be 18, 19, and 20, I think the standard of being able to get them done should be a lot harder to do than just check off a box, what do you want done? And that's all I'm looking for.
And Tani, I think Dr. Hirsch would agree with you on all of that. But
I wasn't arguing with you.
No, I get that. But it's a nice fine point. It's a good fine point on it, because I know it's a passion of yours. And maybe you can't articulate this, or maybe you not, it's too hard to figure out in retrospect, but can you articulate what you were experiencing as a 27-year-old woman? Is there, because I'm asking it only because if you could articulate it, maybe another young woman could think about, am I feeling that way too?
I wanted to feel different. I had lived in my body for 27 years, and I was bored. And I just wanted, and also you have to remember the time too. Back in the early, the mid '80s, don't you find now, Dr. Hirsch, that big-breasted women, that's not really the fashion?
Absolutely, yeah.
What are most people wanting?
Most people want a natural look now.
Yeah.
It's not, we're not putting those 500 cc implants in. Usually you're talking 250 to 350 cc. So everybody wants a full C. Is what we're hearing.
Full C is what they want.
Yeah.
Right. Or just, I'll tell you, I don't know if Susan showed you the picture.
She's going to.
Because I wanted you to see that when you first saw the show.
Bring it in.
Yeah,
Bring it in.
Susan, show him the picture.
All right.
Before he went in, he said, I don't know what I'm going to get. She doesn't have any breast tissue.
Yeah.
So this is going to be, and then he got in, he was like, oh my gosh, she has more breast tissue to work with than I thought.
Good.
So take a look at the picture.
I'm sorry, it takes me a while. She talks a lot. So
what was the second
scrolling
procedure?
Susan.
Her texts are.
Hey, good, Tani. Good for you.
That's
really.
what I said.
Yeah, good for you. It looks
good.
great. It really does.
That's what I said.
Congratulations.
Very good.
Good for Terry,
I'm not
Dr.
gonna-
Bro.
Yeah.
That's all natural with nothing.
Yeah.
And he just put me back together, and I am, my shoulders are back, my personality's back. I walk into a room and I'm in the right body now. I'm me again.
This is what you're actually lighting up Dr. Hirsch, because this is why he likes doing this work. Stuff like that is these guys'
That's
payoff.
ideal. That's ideal. Yeah.
Yeah.
Absolutely. I mean, I'll tell you, Dr. Hirsch, when I went in, I know we were chronologically, but the third, not the second one before this last surgery with Dr. DeBro, I had gone in because I was done. I was finished. I wanted a lift and smaller implants, and then I was going to be done.
Mm-hmm.
Well, you think you're done, but they have to be changed out like every 10 years.
Yeah.
I mean, you can't keep them in, right?
So it sounds like you didn't have, like, from the very beginning, it sounds like your informed consent process probably wasn't great.
Yeah. I don't think they thought about it that way back then as a recurring procedure.
And when you talk about checking boxes off and making sure patients understand exactly what they're getting into.
Now it's that way.
It's like an airplane. You check off all these boxes, your safety checklist before you can take off.
Really?
Yeah, absolutely.
Okay, well, these plastic surgeons down here that did this in Newport Beach, I'm not going to name names, but I know them very well. And so I didn't have to go through the major checklist that I would normally have to.
Don't ever get, listen, this is a great case in point, Tani. This is for everybody. This is for you going forward. Don't ever get special care. Get the standard of care. The standard of care is the standard because it's the best. If you get special care, you're putting yourself at risk for trouble. I don't care what field of medicine we're talking about. Nothing special. We do a standard practice because that's the best. If we're not doing our standard practice, we're doing a substandard practice. Even though it may seem special, watch out. And no more so than in psychiatry and general medicine. Conrad Murray, poster child for this. So,
there you go. So I went in to have a lift and very small implants put in. And I was on the gurney still waking up with the needle, with the anesthetic, still dripping through my veins as I was coming out, and I could not see my feet.
The most recent surgery?
No, this is the one before the last one. Yeah.
This was the two
before
surgery. Okay.
Yeah.
And I woke up and they were about 550.
Oh my God.
I couldn't see my feet and I was still a little out of it because of the medication. And I started crying on the bed. And the nurse, the recovery, the nurse in the recovery room said, they're just swollen. They're going to go down. They're going to go down.
Tani, did you pick that size, or how did they arrive at? Did you talk about it ahead of time, or how did you arrive at 550?
I said I wanted to be a big B, a small C. I just a lift, and that's it. And
that's pretty big for a B.
It's crazy.
Yeah.
And so a year later, they're still that size.
Sure.
So I went back to the doctor. He brought in another doctor, and he said, "Okay, this is what we're going to do. We're going to take them out. The pocket is so big because of the implants.
Of course, yeah.
We're going to put mesh inside to hold the implant that you want in." About 6 months later, all of a sudden, the implants start sliding down.
Oh my God!
That's not good. Yeah.
Oh my God!
Bottom of my rib cage.
Were they coming out from under the fold of your breast?
They were coming. Well, what Dr. Dubrow had said was, not only did they not use mesh, they used cadaver skin.
Sure.
Cadaver
skin could be a type of mesh. It's a terminology issue.
Well, but then tell me.
Sure.
Inform me.
Yeah.
Right.
Informed consent.
Yeah.
So the mesh had. They called it a double bubble, which I'm sure you're familiar with, right?
Yeah, absolutely.
Where the mesh is caught between. So there's an upper boob and a lower boob because the mesh is now right in the middle.
What happens with a double bubble is when you have a breast surgery and they adjust the position of the bottom part of your breast, and then you see that there's actually a picture on my website of somebody who has a double bubble. So that fold is no longer where it's supposed to be, and then you can see that fold on the bottom part of the breast, and it looks like there's two folds.
Two folds, got it.
Exactly. So that's when I decided that there was nobody else on the face of the earth that could fix this. I didn't know you at the time.
It's okay.
That's when I got in touch with Dr. Dubrow. And as you can tell, the man saved my life.
That looks great. Absolutely.
Yeah, and I saw the before. They showed a certain amount of before stuff on TV too, and I felt bad for you. It's
And
and to the psychology of that.
Yeah.
I did not leave my house.
Oh, geez.
2 years. I started getting like agoraphobia because it really started mentally affecting me.
Of course.
So there was just a problem after problem, meant not only physical, but it started becoming emotional and mental issues of I didn't want to get into a relationship. I didn't want anyone to see me naked. I didn't want to date. So I kept in my house, and it was
tough.
So this is the great example of what we started talking about, which is there's mental health manifestations. Is the surgery the answer or the problem? She gets the surgery, it's the answer.
Yep.
Right? And so it's not an easy call. It's not an easy call when Tawny is kind of easy, but in other people it can be tough to know is this going to help or make things worse or just be part of the.
There's no question.
Yeah, it's really interesting problem.
Right.
What else did I want to ask Tawny? Shoot, my brain's not working.
How was the
well
recovery from surgery? Was it really
That's what I
painful
want to
for
talk
you,
about.
or?
That's what I want to talk about.
The recovery, I think people I have gotten, when I looked at my Twitter feed, I had gotten nothing but women and men also saying, thank you for being so brave and thank you for just really, really wonderful. But then I got this one comment about the leeches that they used on me.
Leeches
Kind of like it was an act, like it was a put on.
Oh, no.
But
no, they're real. They're effective. They work, yeah.
The matter is, God, we're friends. I call you Drew.
It's all right. Drew's fine.
Drew, so the day after surgery, you go in and they film you for the show for your post-op, right?
Yeah.
And my breast would not stop bleeding, and they tried everything they could. And I was about to walk out the door. They're up in Beverly Hills. I'm down in Newport, and Terry he had been thinking about this earlier and called in the girl with the leeches. And just as I was about to leave, said, you know what, come on back. We've got to do this. Yeah. And people don't understand that these leeches aren't just picked up off the grass.
Used to be 1-800-LEECHES.
Yeah. There used to be a leech company. Yeah.
Yeah.
And I'm not, but listen, they're more effective than people understand. And everyone's all interested in natural approaches to medicine. This is a very natural thing. They bring the blood to the surface. Yeah, I have been in situations where we've used maggots in wound repair. Yeah. I mean, I would much rather they're much more precise than a medical student with a scraping knife.
Right, and they stop once the skin becomes.
That's right.
Yep,
that's right.
The way the leeches work, they basically have to have a point of attachment for them, and so you can take a little needle and poke it into your skin or something like that. Then the leech will find the blood and stick on. And it'll basically eat. And as it eats, it's sucking the blood out, which helps relieve if your veins are congested or if you're having a problem with outflow. So you have inflow and outflow. Outflows from arteries, outflows from veins, inflows from arteries. If you have a problem with outflow, it's congested, and the leeches will help relieve that congestion. They'll also
that can improve the inflow.
Absolutely, yeah. Because it's like traffic. If you fix the obstruction. They also submit a chemical called hirudin, which will basically help all the blood flow.
And it's a natural, isn't it a natural, Dr. DeBro was saying.
Anticoagulant?
Yeah.
Exactly.
So you bleed, which is good.
Yeah. And then they showed me they squeeze the blood out of the leeches and they can reuse them.
You can, They need a little while.
Susan loved this part, Tony, just so you know. This is her favorite part.
That's the job I want. I want to be the leech squeezer.
So, what I was wondering, and it wasn't specified in the episode, how long did you have to wear them for?
They put them on. I think they were about either 30 to 45 minutes.
So you did it just in the office. It wasn't something you had to use or replace yourself from.
Just a one-time thing.
One time?
Just one time.
Just one time. Okay. They put 3 or 4 on.
Yeah.
But in the car on the way home, I didn't know it, but I was still bleeding.
Sure.
And
probably for a couple hours, no?
Yeah.
Out of the car.
Yeah.
Yeah. And I got out of the car and there was blood everywhere. And I called Dr. DeBro and he said, get to my office immediately. And I met with Jackie, his nurse, his man. And she had to cauterize me.
Oh.
Very effective leeches.
There's another interesting with Dr. Hirsch you could talk about. That is fascinating.
Yeah, it's interesting how that works.
What did they cauterize? Was silver nitrate or something? What did they use?
It looked like a matchstick.
Yeah, silver nitrate. Silver nitrate. Yeah.
Just it's a chemical that cauterizes the vessels.
Yeah, and it's very superficial and it's very easy to tolerate.
So I have been through, the spectrum of, and I am so, and I was so happy to hear that Terry say, that most girls in my position would ask for something to be put back in, and that he was proud of me that I didn't, that I just wanted to go all natural.
Can I be all male here for a second? And why would you? It looks great. I mean, why would you mess with that?
I'm glad you asked.
Yeah.
I'm glad you asked because when I walk down the street, if there's 100 guys looking at me, now that I don't have such big breasts, I've lost 25% of those guys. And you know what I think? I think I've dodged a bullet.
Well, yeah, those are the 25% you would like to not have looking at you.
I said, I don't want to be in those kind of guys, their lineup anymore. Yeah. That's why I said, no, I don't need them anymore. I want a man who likes me for here and what's in here, not what's out here.
And you want to talk about the well, first of all, let's quickly say did you develop a seroma also afterwards, or was it lymphedema or both?
The edema.
Yeah.
Where was the edema?
The edema was in my legs, and that was going through the summer wearing those compression stockings.
Yeah.
Was and I still have them on. I completed at Hoag my 2 weeks every day, 90-minute sessions
Of the compression, of leg compression. Yeah.
Yeah, with an actual person, doing the work. And
that's pretty unusual after surgery.
Yeah, I'm trying to figure out what this was. Was it lymphedema or was it just peripheral?
Yeah.
Lymphedema.
Lymphedema. Were your arms swollen too, or just your legs?
Just my legs, because it was from everything from the waist down, because that's where.
Oh, interesting. You're right. And
yeah. It was.
It's miserable.
And I'm still dealing with it, and it's. But I'm at the point now, like Dr. Terry said, he got me to a vascular surgeon this quick. And she said, okay, this is what we're going to do. Got me to Hoag. And he's just, most doctors are like, well, that's not my fault.
Oh, yeah, no.
It doesn't have anything to do with what I did.
Yeah.
And Terry took full responsibility and said, this is from that, and boom, let's take care of it.
Did you have a blood clot or anything like that?
Sorry?
They look in your legs for a blood clot or anything like that?
That's what the vascular surgeon did. Sent me straight for the MRI.
Yeah.
Contrast, non-contrast.
Right. It was negative or
negative? Yeah.
Okay. Good,
yeah.
So it's all lymphatics, which is a not dangerous, big nuisance. Doesn't have. Go ahead.
But unlike veins where they can get clogged, as you know, I'm not teaching you anything new. The lymphatic system breaks.
Can,
sure.
Yeah.
And so we think we caught it soon enough that for people who don't know what it's like, it's when you see older people and their legs look really big.
It's actually not like that though, because that can really get out of hand and get bad. What you have looks like that a little bit, but it's not that. It's not going to keep progressing, it's actually a little harder to control, but it's not as progressive. So that's the good news.
Right.
It sounds like the therapy was effective.
The lymphatic drainage through and it feels good too, right?
Yeah.
Absolutely,
it's a 90-minute massage.
Yeah, right.
So, but they're expensive massages.
Well, the insurance should be covering that, no?
Yeah, they'll cover everything but 20%. And
all right.
Not so bad.
All right.
Not so bad.
All right, so you can make a deal with them. Maybe they'll.
Yeah, I'll get a super bill from Hope Hospital. I'm looking for that pretty soon. And then I'll be calling Terry going, hey, how much do you love me now?
I love this. All right. Well, listen, Tani, talk to us a little bit. I'm going to let you go after this last bit, which is about your again, you touched on it a little bit, but talked about, what did you call it? The boob campaign, or what are you calling it? Go ahead.
The
boob train. The boob train. Go ahead.
Yeah, because once you get on, you can never get off.
So you. Wait. Susan has a question for you from Facebook.
I don't know if my mic's on because I
It's
turned
on
it
now,
down.
yeah.
It was so loud.
It's on.
So somebody asked why you have to change your breast implants after 10 years.
Sure. They're not lifetime devices. Like any mechanical device, they can have problems. Your body can change with time. The implants can wrinkle, they can even rupture, they can leak. And so, like any device, they have a shelf life. And you don't have to change it after 10 years, but you don't want to be 30, 40 years down the road and say, wow, I just got a mammogram and I got silicone everywhere. So, 10 years, start seeing somebody and make sure that you're followed regularly by a plastic surgeon. And then when the time comes, you'll be ready to switch them out and maybe go bigger, maybe go smaller, maybe do a lift, something, or take them out completely.
Right.
Encapsulation.
Encapsulation,
Yeah,
sure.
that's the most common thing.
What happens anytime you put a foreign body into your body, if it's a breast implant or a shoulder, hip, knee, whatever, your body forms a protective capsule around it.
Or a splinter,
Or
or
a
whatever
splinter.
it might be. Anytime a foreign body goes in, this is how your body walls it off and sometimes pushes it out.
So they see it as it's like an attack on your immune system, and so you're trying to seal it off so it doesn't cause problems. Occasionally, in breast implants, they can get hard and painful, and that's called capsular contracture.
Right. And isn't there something about the textured implants that have been known to cause they can call cancer?
Sure. This is new stuff. You're talking about the past 4 to 5 years where this kind of came to light. The short story is that we don't know about causation. We don't know for sure if this is caused by breast implants, but there's an association between textured silicone breast implants and the development of a breast implant capsule specific lymphoma. It's called ALCL, breast implant associated ALCL. That's kind of a short story, but at the same time, you're talking about there have been about 400 cases ever reported, and there have been millions of women who have breast implants, not just for cosmetic purposes, but for reconstructive purposes as well. And so what I tell patients is that we are investigating this. There may be an immunologic link between textured breast implants, a certain type of bacteria, and development of this phenomenon. But your chance of getting this is about the same as getting a HIV from a blood transfusion. So it's really low. You're talking 1 in a million, 1 in 10 million. So does it exist? Maybe. We're investigating it. Should you be worried about it?
You avoid those implants.
You avoid those implants.
For sure.
Yeah, definitely. Yeah, thank you, because that is definitely avoid those implants.
Avoid implants,
yeah. And well, Tani, are you like literally getting like a website together or anything, or?
Well, actually, can you keep them quiet for just
2 more minutes? 2 more minutes, and then the dog.
It's the dog alarm.
That never felt the need to get implants, and she's one of my best friends, and I applaud her so much. Really, I am so proud of you. Yes, there is. We are. It's a breast implant victim advocacy. It's at BIVA_news. And there's just we're, going on, really trying to get some awareness on the Senate floor on just trying to get, listen, our food, we know what's in the ingredients in our food, but we have no idea. It's under a protective act of what is actually in the implants. We can't, isn't that true, Dr. Hirsch, that we don't know what the ingredients of the implants are?
Well, it's I'll put it this way.
I put you on the spot, and you didn't.
No, it's okay. It's
I'm trying to do all that I can to try to help mentally and physically women just really, really think about this before they go. And I'm sitting here. I'm a victim of problems, and I'm trying to save as many people as I can to not go through what I've gone through.
Again, I don't think he would disagree with you on that.
I think the bigger issue, it's not so much. I mean, are implants toxic? No, absolutely not. Are there chemicals? There's chemicals in everything. There's silicone in lipstick, hair products. I mean, it's everywhere. But absolutely. I think the bigger issue, Tani, is the informed consent process and making sure that you and other patients really understand what they're doing and that this is not a one-time thing.
Absolutely.
All right, honey.
Thank you for that.
Great to see you, my dear. We'll hopefully see you in person soon. Thank you for spending a little time with us. Thank you for, being such a great example for other women. We really appreciate it, and thanks for spending time with us. And enjoy your friend there. Say hi to her for us. So
she's saying hi. All right, Dr. Hirsch, it was so nice to meet you, Tani. It was such a pleasure.
All right, Tani.
True. You, Susan, I love you, and I'll bombard you with texts later.
Okay.
All right, Tani. Talk to you soon, and we will take a little break and be right back.
Bye bye.
Quick break, and then let's go right.
How do you turn this off?
Am I talking about?
I don't want to hear you anymore. Bye, Susan. I'll talk to you later.
Bye.
Okay.
All right. Bye, Drew. I love you guys.
So now we'll talk more about it. Sure.
Okay.
Ready?
Yep.
You want to talk about Alliant or Hydrolite?
You're still on
Alliant or Hydrolite? Susan?
Hydrolite.
Okay. And we are back, and
you have a new thing, a new.
Do I have to read it?
Yeah, look it over. We're going into flu season.
Okay.
So.
Yeah, friend. Welcome back, and I just want to remind everyone about our friends at Hydrolite. It is flu season coming in soon, and I cannot say it strongly enough. This is a great formulation. The Hydrolite formulation is scientifically based. It's proven with science. It is probably. I think it's the best rehydration product I've tried. It comes in great flavors. Just a tablet you put in water, and whether it's vomiting, diarrhea, fever, this is equivalent to IV therapy. So it can really help you feel better, staying hydrated if you have an acute illness. And of course, it's also good if you're athletically inclined or during these summer months. We've gone through tons of it in this household. Susan, how much Hydrolite did you drink this year?
I drink it every day.
Yeah. Okay, we're back with Dr. Elliot Hirsch. Thank you, Tani, for having joined us. And, of course, Dr. Hirsch is a board-certified plastic surgeon. Let's talk a little bit about, we'll go back into the breast topic. We've sort of boobed out for the moment. Let's talk a little bit about the process of becoming a plastic surgeon and the landscape of cosmetic surgery, because it's very confusing, even to me now sometimes. I have to really kind of look twice at what it is somebody's talking about when they say they're a cosmetic surgeon. So go ahead.
Yeah. Well, it's funny you bring this up. I have this conversation in the hospital all the time. If I'm working in the OR, some of the techs and nurses that we work with, they don't even understand. So, I mean, if you're in the medical field, you understand. I can only imagine what the patients are going through.
Right.
So somebody who is a board-certified plastic and reconstructive surgeon, it means they've gone through a accredited plastic and reconstructive surgery residency.
After a general surgery residency, though, right?
It can be.
Or at least part of it's general surgery.
Yes.
Yeah.
So the way it works, you do 4 years of med school, and then in your 4th year of med school, you do a process called the match, which is where you decide which program you're going to go to. There are 2 types of plastic surgery programs now. There are independent programs, which are 3-year programs after 5 years of general surgery, or there are what I did was an integrated program, which it was 7 years long, but it's a combined plastic reconstructive surgery. So
you save 1 year essentially.
Yeah, pretty much.
And is that because they let you go into the plastics a little bit earlier?
Yeah, absolutely.
So you're not just doing bowel resections for 4 to 5 years?
I can count on one hand the number of bowel resections I've done, and I'm thankful for that.
Yeah.
But it's a different concept for training where instead of doing colon surgery or GI surgery, I did orthopedic surgery, I did ENT, I did oral surgery.
Oh, that's interesting.
Yeah, so I can remove wisdom teeth. I mean, not that I do that anymore, but in training we do that. And these fields are much more related to modern plastic surgery than are the GI fields.
That's, of course, right?
Yeah.
I mean, once you go into the abdomen, that's its own
Pretty much.
territory. That's it.
Yep.
I mean, I guess you get good at surgical technique, but that's about all it gives you from the standpoint of plastics.
Pretty much.
Well, it's because I've always said that when it comes to facial reconstructive surgery, I'm a little more towards the ENT guys because that's, you know what I mean? Because that's where they spend their time and they know that anatomy cold. Now you're saying you've had a bunch of that as well now.
Absolutely. And if you look at so the ENTs have different types of specialization. So you have the plastic and reconstructive surgeons who have trained,
more towards general surgery.
A little bit of general surgery, but kind of a broader spectrum. And that is one type of board certification. It's the American Board of Plastic Surgery. And so after
I'm going to make sure this is the part I get confused about.
Okay.
If you do not do an integrated residency,
Yes.
general surgery and plastic surgery, or
Integrated
multiple
or independent,
surgeries,
sure.
are you only eligible for a plastic and reconstructive surgery residency if you've done a general surgery fellowship? If you've done a general surgery residency, can I be an orthopedist and do a plastics? Okay.
Absolutely, yeah.
Okay.
You can have an orthopedist who has done their orthopedic residency and then a
So
plastic
what are
surgeon
the
on top.
surgical fields that could go into a fellowship in plastic and
Oh,
reconstruction?
anybody can do that.
Any surgeon.
Yeah,
So
absolutely.
ENT, ortho,
Urology,
chest surgeon,
Sure,
urology
yeah,
can go
they
into
want,
it.
yeah.
Why would a urologist do it for the general
Yeah,
reconstruction
absolutely.
stuff?
Yeah.
But then again, the fellowship has to focus in those areas, right?
Well, the fellowship, so after you do your initial surgical training, your fellowship is a 3-year long plastic and reconstructive surgery fellowship where you do the full spectrum of plastic and reconstructive surgery, not just.
But why would a urologist have the training to do the full spectrum? That's what I'm thinking.
You pick that up during those 3 years. So
they're trained in it. Okay.
Yeah. So they have the basic,
catch up.
Exactly.
They catch up.
They have basic technique, then they figure out the rest of it.
Okay. Well, that seems like a lot of catch up.
It's a lot of school.
Well, but a lot of catch up too. I mean, if you've been down below the navel for your entire residency and doing kidney transplants, and then all of a sudden you've got to do a nose or a neck or something.
Well, a lot of things that they do actually translate pretty well.
Okay.
Like a kidney transplant, like you said, that translates well to a breast reconstruction with the microvascular surgery where we unhook the abdomen, the abdominal wall, and an artery and the vein, then sew them into an artery and vein in the chest to build a new breast. So,
you, as a non-surgeon, what's freaking me out is technically that makes perfect sense to me, but having such familiarity with the anatomy that you can improvise and respond to things and stuff, that flips me out completely. But that's maybe why I didn't go into surgery.
Well, it's a long process, and I had more hair when I started.
So keep going. So there's the general reconstructive plastic surgery.
So that's the plastic surgery side of things. Then you have the ENT side of things, and the ENTs have a special facial plastic surgery fellowship. So they have done a 1-year fellowship after their 5-year ENT residency.
Okay. And sometimes those can go a little longer, right? They can specialize in eyelids.
They
things
can,
like
yeah,
that, nose.
absolutely.
Yeah, okay.
So
that's 1 or 2 years.
1 or 2 years. That's the ENT side of things. Then you have the oculoplastic surgeons. So these are ophthalmologists who have done, usually they do their general ophthalmology residency, which I think is 3 or 4 years.
I think it's 5 now.
Is it 5 now?
Yeah.
Okay. Then they often do a 1-year oculoplastic fellowship, which basically gives them additional training on doing eyelid
We
surgery.
have a good friend, Susan Dr. Stout, is this kind of surgeon.
Yeah,
and
he's great,
he does
too.
eyelids like crazy.
Yeah, absolutely.
Dr. Warren Start in Pasadena.
Yeah.
Shout out.
Yeah.
Then those are kind of the mainstream accredited by the GME, the Graduate Medical Education.
And to be fair, those are the highest levels of training, around plastics. But then there's all these other ones.
Well, then you get out into the
and even there you can get a little goofy too, like the
Yes.
ENT guys going into the breasts. That would concern me greatly.
Well, they're not supposed to go below the clavicles.
Right.
It's not.
So again, something for the public to know. So
Yes.
good. Okay, go ahead.
So then you go
the rest of it.
The rest of it, yeah. And there's a board, American Board of Cosmetic Surgery, which is I think it's a 1-year fellowship just doing cosmetic surgery. But like you said before, that could be a dermatologist who does a fellowship. It could be family practice doctor who has no surgical training. It could be an OB-GYN. And then the big issue with that board is not accredited by the American Board of Medical Examiners. So that
it's a certification.
Certification.
It's not a board. People get confused between certification and board certification. They are different things. Very different things.
Very different things. And I think about my board process, and that was
brutal.
A lot of anxiety. Yeah,
Brutal.
A lot of anxiety.
And my understanding, the orals and plastics are pretty rough.
I said I lost hair, and I think during that 6-month period when I was preparing for my boards, that was the end of my hair, and just a lot of stress right there.
And that was just the trichotillomania. You pulled it out. So what are those guys? What is there anything we could say that the people there's different cosmetic surgery certifications too, right? Aren't there a few of them out there?
Once you get past those main ones, it starts getting kind of confusing.
Well, that's what
and I don't even understand all the different types.
Okay, well, that's what happened to me. I was looking at Michelle and I were looking at some stuff, and I was like, oh no, this is cosmetic surgery certification, and I'm not even sure what we're looking at here. But you generally look. The American Board of fill in the blank is what you want to look for in whomever your doctor is, whether it's cardiology or general surgery
Absolutely.
or plastic surgery or internal medicine or psychiatry. American Board of. That's what you want.
Yep.
And the certifying groups, finally addiction medicine has an American board, although it's not fully in place yet, my understanding is. And so that addiction medicine will be a board also. But that is a certain level of standard of expertise that you can rely on that other countries don't even have.
No, absolutely.
This is something unique to our system.
And you should, that when you are thinking about doing a surgery, you should definitely ask your surgeon if they are board certified in whatever field it is. And it's not just what we do. Like you said, if it's heart surgery or, although it's hard to imagine anybody doing heart surgery without being trained.
Who knows?
You never know.
Yeah, you never know. All right. So and the cosmetic stuff. Is there anything on the cosmetic side that we would be okay? Like I guess they could do injectables, things like that. And
you can do Botox.
So dermatologists that have a cosmetic certification that do injectables, good. That's kind of good.
Sure.
Right. And they may have some specialized training that really would be helpful to them as the dermatologist.
Absolutely.
Right? Yeah. I can't really think maybe a dentist have something, or they have their own boards, right?
Well, you think of it like this. A dentist spends 4 years working on teeth.
Yeah.
Is that the person you want injecting your Botox?
Not necessarily, but they have other layers of certifying for cosmetic dentistry. Yeah.
But you wouldn't necessarily want the same person.
No.
It's just different.
Well,
story.
but then again, I might be okay with them injecting my chin or my laugh lines or something. You know what I mean? They know the mouth. They know the mouth.
Potentially, but once you get outside, then you're talking. Fillers seem very benign.
Yeah.
But I like many other plastic surgeons, I've seen horrible things that can happen with fillers.
What can happen?
If you inject a filler into the wrong space, you can embolize the filler material into an artery or into a vein. It can cause blindness. It can cause skin necrosis. These can be really catastrophic, irreversible complications.
So blindness from it being injected around the eye kind of thing?
Yeah, and actually, there are a lot of people who inject under the eyes, and I get asked about this all the time. I don't do this in my practice. It's just
too dangerous.
Too dangerous, yeah.
Susan, you ever been injected under your eye?
Yes.
Let's not do that anymore. Was Dr. Stout doing it?
No.
Okay, nobody else does that.
If you are somebody who needs injections under your eyes, you probably want to think about a lower lid blepharoplasty.
Okay, Susan, lower lid blepharoplasty.
Something to think about.
Yes, I am thinking about it.
There you go.
But no more, no bueno.
No, actually, I was talked into it. I just went to somebody else, and then it was really puffy. It didn't go away, so I had to have hyaluronic acid put in there because I thought my eyes were puffy, but then I went to Nurse Jamie, who's very reliant and reliable, and she said that she thought it was the leftover
Injectable.
Injectable, yeah. So you have to go to someone who knows what they're doing or not do it at
I've
all.
seen this all the time too, and a lot of the issue is the lower eyelid skin is so thin, and the lower eyelids are so thin, they don't have great lymphatic drainage, and so when you get something injected into that area, it can cause
It doesn't come out.
inflammation.
It doesn't come out.
Yeah.
But when you have your blepharoplasty, they'll take it out. Don't worry. So,
I'm old. I have
we're
wrinkles.
bumming her
and
high a
puffy
little bit.
eyes. I'll do
She doesn't
it.
look
Let's
happy with
go
you there.
tomorrow. Sign me up. Let's go.
All right, and so now let's go down into the breast discussion again,
Sure.
and sort of what you want people to know about that. And Tawny's a point of view, and she's had her experience, and she's trying to be reasonable and whatnot. That's good for her. I don't quite understand where she got the lymphedema from. Did they tie something down? Did they get the thoracic duct? Or
Well, do you know if they did any lipo or any
No.
fat grafting or anything like that? Nothing, just straight lift.
I'm trying to figure out how they got the lymph. Well, she said the surgeon knew how he caught it. I don't quite get it.
Yeah,
But that's an unusual complication.
very unusual.
Yeah.
I mean, I've seen upper extremity lymphedema,
Which
after
is
breast
common,
surgery.
which
Yeah.
is really common.
Absolutely.
And frankly, I would think that'd be more problematic.
I don't want to get
Can be.
Paul involved in this, but he did say that she may have had the reason why she wanted to take it out is she had some pre-existing problems.
Something that might have contributed to this lymphedema
Maybe
issue,
she
some
had
scarring or something.
else.
Her
Well, but-
kidneys were or anything like that.
But he doesn't
some
want to
medical
say
problem.
anything
Medical
because
problem, yeah.
it's not his case.
All right, we'll get Terry to Brown back. But common thing after mastectomy is lymphedema in the upper
Oh,
extremities.
absolutely,
It's just routinely a thing, and so I
Yes.
assume. Do you see that often after the cosmetic breast surgeries?
No, usually
Yeah.
not.
Yeah. And why is that? Why is it so different? Because much less tissue destruction, or
Well, mastectomy lymphedema, that can happen more commonly. It's associated with the lymph node dissection.
oh,
and
that's why.
radiation.
I see. Okay.
Radiation's the
So
big
it's
one.
not the surgery.
No.
It's, okay.
Well, I mean, it can be if you do a lymph node
Dissection, a big one. Yeah.
takes out all the lymph, so
That's
where's it
that.
gonna go.
Right.
But
Fair
the
enough.
radiation causes fibrosis of everything. Then you get the lymphedema.
What are you most excited about now? Are there new things on the horizon, or things you particularly want people to know about, or are looking forward to doing?
In the breast reconstruction field, I think the newest thing is the nipple-sparing mastectomy. And these are patients, so before we touched a little bit on the prophylactic mastectomies, people who don't have breast cancer, but they have the breast cancer gene.
The BRCA genes.
Yeah. And if you have the BRCA gene
And a first-degree relative,
yeah,
you're in trouble.
big trouble. You're
Yeah.
talking like 80-90%.
Yeah.
So we're seeing more and more younger patients now who are finding out they have these genes, and they're getting mastectomies.
But by the way, there's something called color.com if you want to get tested. They are extremely good. It's just if it's $250, I did it myself. I have no relationship with them, but I just am so excited about genetic testing. It's $250.
That's
3 or 4 years ago, it
great
would have
deal.
been $5,000, $10,000, and they check for the 30 top genes. I have it's called a Lynch gene, MSH6.
okay.
Turns out my
What's
sons
that?
have it too. It's a GI cancer gene.
Ah,
It's
great.
in the sort of polyposis zone. And so guess what? I bought myself colonoscopies every year. That's what that does. And my kids start to get them at 25 as opposed to 50. So we're all going for a family thing this go round.
I can only imagine how
So
that's,
tell us more about well, with what we screen for it. It just
Oh, you
changes
have
the
to do it,
screen.
yeah.
So the nipple sparing, keep going.
Yeah. So nipple sparing mastectomy now, for these younger patients who have the breast cancer gene or some other type of genetic reason to have a mastectomy, we can actually save their nipples. Which it sounds like, is that a big deal? It's
Really,
a nipple.
it makes things look really
It
natural.
makes a huge difference
Yeah.
because it doesn't change the shape of the breast envelope.
Yeah.
And so you can do a direct-to-implant reconstruction where in one stage, breast tissue comes out, implant goes in, and a lot of these times these patients look like they had a breast augmentation, so they look better after surgery than they did before it.
How do you save the nipples? About rehooking up the blood supply in some interesting way, or
There's a couple different ways.
Yeah.
The best way to save the nipple is work with a good breast surgeon. They're going to respect the vascularity. They're not going to go through the skin.
Got
They
it.
won't leave too much behind, but they'll take just the right amount off.
are you there during that procedure, or you come in after?
It depends who it is.
Yeah.
Sometimes I'll be there just kind of watching. I know that I'm not trying to make them nervous on purpose, but if I'm looking over their shoulder,
Well, you can
I
be
know-
helpful. You can be useful.
I can retract a little bit.
Right, so that's exciting. What else? Anything else out there in plastic? Anything that do you think is going to sort of expand the field, that more people will start to? I'm thinking about injectables and
Injectables
skin
and fillers.
stuff. There's a lot of stuff out there now.
There's a lot of stuff. I do a lot of breast implant removals. I think a lot of plastic surgeons do, and we don't talk about it that much because these are cases that, like Tani looks fantastic.
Yeah.
She is lucky. She has some tissue to work with. The issue she had with the nipple vascularity, that happens fairly commonly after this. I have a slightly different way of doing the surgery, where instead of creating what we call a pedicle for the nipple, which is going to be the blood supply for it, instead of creating one pedicle, I found kind of a modification of a technique to use 2 pedicles, so it doubles the blood supply. And so since I started doing that, I haven't had any nipple problems, and it also leaves more tissue behind to help shape the breast.
Oh, interesting.
But I think if you're talking about the biggest advance in plastic surgery in the past 5, 10, 20 years, fat grafting. So we can take fat out without doing a big and aggressive procedure and just basically liposuction fat out and re-inject it.
As a stem, spin it down as a stem cell?
Spin it down.
Yeah.
So
And then you put some, I was heard Dr. Nassif was saying they put some platelet-rich plasma in with it to help it stay.
You
right?
can, yeah. And that's something that they're kind of working out.
Yeah.
It's not been proven. But things like a butt lift, for example. A Brazilian butt lift is liposuction then re-injected into the butt. In patients like Tawny, a lot of the times I'll do fat grafting where I'll suck the fat out of their abdomen and then move it into the breast.
And it stays. I understand how it stays.
Some of it stays.
Yeah,
some of it stays.
but still, it's remarkable to me.
It's great, yeah.
That just takes.
Absolutely.
It's crazy.
Even in a modern facelift now, a lot of facelifts will incorporate a little bit of fat because the facial fat will atrophy as you get older.
That's what we got into this conversation about the platelet-enriched plasma and stuff too, because he thinks that helps some secure some of it. So
it does, yeah. And we have an esthetician who does PRP micro needling, where she will apply the PRP to the face and then needle it into the skin, which helps boost the collagen synthesis and really helps smooth out the skin. I mean, it looks fantastic.
Platelet-rich plasma, PRP.
Yeah, absolutely.
Yeah, there's a lot of application for that now, and as opposed to stem cell.
It's different.
Yeah.
It's different. When you're doing stem cells, you're getting the stem cells from the fat. I mean, they're also in the bone marrow, but you're not going to do a bone marrow harvest just for cosmetic application. But stem cells will theoretically help regenerate the actual cells, whereas when you're doing a PRP, you're putting growth factors and other things to help. It's kind of a different way of stimulating.
Anti-inflammatory and growth.
Yeah.
So. All right, well, Dr. Hirsch, I really appreciate you being part of this conversation. It's been very interesting. Susan, do you have any questions? I know you love talking about plastics. No. So, you have anything before I wrap this thing up? Nope. All right, well. Tell everybody where to go. Check out, do check out our family of podcasts at drdrew.com. We got of course, our weekly infusion, and Bruce is out for a couple of weeks, and so I'm doing them on my own. I'm having a good time without him. Don't tell him. And I've got also the You Live version of the This Life podcast with Mike Catherwood. We've got me and Bob Forrest. We've got some good stuff coming up, and do keep checking out the Facebook Live. We've got, I think, next week some good ones coming up too, right? Yeah, so keep an eye out. Yes, the 100th episode of This Life. This Life, and so a bunch of celebrity rehab guys are coming back to join us. Again, drdrew.com, as you check that all out. Dr. Hirsch, what are your websites? Tell them about that.
Yeah, if you want to learn anything more about what we talked about today, and if you want to see pictures of any of these procedures, my website is www.hirschplasticsurgery, HIRSCH plasticsurgery.com, and we are in Sherman Oaks, California, in the beautiful San Fernando Valley.
Great. Thank you. We appreciate you being here. Really,
Thank
very
you.
interesting. So,
it's good to see you again.
And we'll see you all next time.